So without further ado, I'd like to now invite our panelists on the stage. Dr. Rajkumar Sachdevani, I cannot see him here. He is the president of the Pakistan Cardiac Society. Dr. Bilal Mohyuddin, Dr. Fawad Farooq, Professor Nusrat Ara Majid has joined us. Professor Dr. Syed Tahir Shah, please join us on stage. And Professor Nazir Mehman, I believe all of them will be joining us. So without further ado, let's start with our first talk. And it will be delivered by Dr. Anna Beale. And it is about physical function, activity, and hospitalization in HFpEF by sex. And Dr. Anna Beale is a specialist and an expert in the subject, so we are delighted to be hearing from her. Please proceed, Dr. Anna.
Thank you very much for the invitation to speak, and good afternoon. So, as mentioned, I'm a cardiologist. I specialize in pulmonary hypertension and heart failure with preserved ejection fraction, and my PhD looked at the role of sex differences in HFpEF. So you may have seen this figure about the proportion of patients according to their ejection fraction and the gender spread. And it highlights predominance of men amongst those with a reduced ejection fraction, which is characterized by those with coronary disease, myocyte loss, this scar formation, and high cardiovascular mortality. Conversely, women predominate amongst those with a preserved ejection fraction, with marked exercise limitation and reduction in quality of life, despite better survival and lower cardiovascular mortality. Much of my research is focused on understanding why women are overrepresented in the cohort of patients with heart failure with preserved ejection fraction, and to understand the sex differences in risk factors and physiology of HFpEF. I started out by examining both intrinsic sex differences and also epidemiological factors which could predispose women towards HFpEF. Women have poor diastolic reserve, they have greater arterial stiffness and pulse pressure, they have smaller vasculature and more microvascular disease. They experience concentric cardiac remodeling with also systemic differences in immunity and inflammation. Epidemiological factors also differ in women versus men, with women having a high prevalence of obesity and stronger relationship to HFpEF development. Menopause leads to hypertension with endothelial dysfunction and increased cardiomyocyte size and fibrosis. And then there's possibly a role of pregnancy and particularly hypertensive disorders of pregnancy. And what this leads to is higher left ventricular filling pressures in women with lower stroke volume recruitment, a greater pulsatile afterload, pulmonary vascular dysfunction, and due to the prevalence of obesity, they will be likely to have the obese HFpEF phenotype, which is associated with a poorer prognosis. I'd also like to highlight this paper, which is from Andre Lagersh, who's a cardiologist also from Melbourne, Australia, who specializes in sports cardiology. This paper looked at the relationship between physical activity, cardiac dimensions, and HFpEF. And this is of direct relevance to sex differences in HFpEF development, but also activity and function, particularly given the figure on the right demonstrates that at any age, women have a lower VO2 peak, and they fall below the threshold of functional independence much earlier than men do. I'll refer you to the paper for a lot more detail, but essentially, he describes that small ventricular cavity size is associated with increased chamber stiffness, meaning that challenges such as volume loading or exercise are more likely to precipitate pulmonary edema. Typically with aging, the heart does become smaller and stiffer. However, exercise training will attenuate these changes. However, physical activity throughout the life course will predispose to the development of HFpEF. The lower physical activity and cardiorespiratory fitness amongst women, coupled with the smaller chamber geometry and somewhat blunted cardiac chamber enlargement in response to physical training as compared to men, may help to explain the higher prevalence of HFpEF in women. To investigate these factors and how they may impact physiology and hemodynamics in HFpEF in women versus men, we looked at patients referred for an exercise right and heart, and this is a video procedure that we use in Melbourne, with symptoms and clinical features suggested that they had a good progressing status. Exercise is integral to the diagnosis of HFpEF, particularly in patients in the earlier phases of the disease, who may have normal resting filling pressures with a dramatic rise in pressures with exercise. You can see an example of a patient here where the resting pressures at baseline fell within the normal range. However, with leg elevation, but then subsequently exercise, particularly, there was this dramatic rise in the wedge pressure. And you can see this illustrated in the initial description of the response of patients with HFpEF to exercise from a wedge pressure perspective that was described by my director, Professor Kay, back in 2013. These tables are from my research during my PhD, and this is where we looked at sex differences amongst all patients with HFpEF evaluated with right heart catheter studies. With exercise, you can see that women were overrepresented amongst this cohort. And in terms of their baseline comorbidities and epidemiological factors, the only significant difference was that of ischemic heart disease being more common in men. However, there were numerous differences in the hemodynamic scene, and as you can see, the wedge pressure was higher with exercise when indexed to workload or stroke volume, and particularly the delta. They also had lower stroke volume and stroke volume recruitment. And we then did some calculated values derived from the measurements taken, including compliance, which reflects arterial stiffening, and also mirrors multiple studies in the literature demonstrating higher arterial elastance in women. And systolic elastance, reflecting ventricular stiffness, was even higher in women accordingly. The arterial ventricular poppling ratio was lower in women, indicative of impaired pairing of the arterial and ventricular systems and affecting functional capacities. And this figure really summarizes the findings of that paper. It's just that there's a complex interplay of factors that affect exercise tolerance in women with HFpEF. They have central to this elevated filling pressures, and multiple factors reflected that. They also have higher systemic vascular resistance and lower compliance, and that's something that we talked about in terms of the predisposing factors. Importantly, they also had impaired peripheral oxygen handling with higher lactate response to exercise, which may reflect that they have poorer skeletal muscle conditioning as well. And then also they had impaired pulmonary vascular function, which may reflect chronicity, but may also be an independent worsening in women compared to men. This is a really fantastic paper from Jennifer Ho's group in Boston, looking at contributors to exercise limitation and how they affect women versus men with HFpEF. They evaluated almost 300 patients, of whom almost 60% were women. And despite having fewer comorbidities and reaching a similar percent predicted exercise capacity based on VO2 max compared to men, women had distinct deficits in multiple components of the oxygen utilization pathway. This included lower maximum voluntary ventilation, worse biventricular systolic reserve, worse diastolic reserve as measured by the wedge pressure to cardiac output slope, and importantly, poorer peripheral oxygen extraction. And so these factors were examined in multivariate analyses, but persisted nonetheless. There's a similar paper that was published. This is just an abstract from ACC this year that similarly found greater impairments in exercise performance in women as compared to men with HFpEF. And together, these studies highlight more severe impairments relevant to physical function in women with HFpEF, with adverse hemodynamic profiles and lower exercise capacity. Just to finish, I'll just talk about some of the factors in terms of hospitalization. So there's been sex-specific analyses of several HFpEF trials, and they've shown similar rates of hospitalization and lower risk of death in women with HFpEF as compared to men. So on the left, we have an analysis of the iPreserve trial that included approximately 2,500 women. And on the right, we have an analysis of HFpEF patients included in the CHARM-preserved, iPreserve, and TopCat America trials. And consistently, what they demonstrated is that women seem to have better MACE with poorer quality of life overall. So just to finish and open up to questions, this is a figure from our review on sex differences in heart failure more broadly, but it's just highlighting that there are still significant knowledge gaps with regards to the prevention and management of heart failure in women. I think the physical activity rates do have a lot to do with this. Reflecting back on that paper regarding cardiac chamber size and physical training from Dr. Lagersh, but there appear to be a number of other abnormalities beyond this, and hopefully we can build on this knowledge to improve on the health of women in the future. Thank you.